plane, we are in essence cutting the plane which is shown by the blue glass plane, if you like, here. And what this shows us is a transverse section of the fetal thorax. And this is important because it's the only view of the fetal heart which has external reference points. Although not shown here, the four-chamber view of the fetal heart lies in the same plane as a single rib in the fetal thorax. And we can name the structures as we've seen from the previous diagrams, with the left atrium most posterior, nearest to the aorta and spine at the back, and with the right ventricle most anterior. And with knowledge of those structures, we can therefore name the right atrium and the left ventricle as shown. We will perform the scan by sweeping from the four-chamber view to see views of the great arteries. But we can appreciate on the four-chamber view that the mitral valve on the left is inserted slightly further away from the apex of the heart than the tricuspid valve here on the right, and that the right ventricle has a rougher texture with a moderator band rather than the smooth-walled left ventricle. What we're going to look at here is the appearances of the normal fetal heart on standard screening views. Now, the core view which is recommended is to start with the four-chamber view of the fetal heart, and this is the only view of the heart with good external reference points. So what you will see as I zoom this image up is that there is a single rib around the fetal thorax, and this marks the plane of the four-chamber view. When we look initially here at the size of the fetal heart, we can see that the fetal heart occupies about 1/3 of the area of the thorax, and that the apex of the heart is pointed anterior and leftwards. We should see that the left and right hand sides of the heart are symmetrical. In order to work out which is left and right, then clearly the position of the apex of the heart needs to be worked out once during the examination. But having done that, in the normal heart, the right heart structures are more anterior, nearest to the anterior chest wall, and the left heart structures are more posterior, nearest to the spine. So here we can see the left atrium, which connects through to the left ventricle through a mitral valve, and the right atrium, which connects to the right ventricle through the tricuspid valve. The left ventricle and right ventricle are of similar size, and it can be seen that the left ventricle has a typically smoother wall than does the right ventricle, which is more coarsely trabeculated here, particularly towards the apex. The mitral valve inserts further from the apex than the tricuspid valve does, and on the ventricular septum, atrial septum, and the atrioventricular valves form an offset cross. Offset in the sense that the mitral valve is further from the apex than the tricuspid valve. There is a natural communication between the two atriums in this position, known as the foramen ovale, and there is usually a hint of the pulmonary veins draining to the back of the left atrium. Both of the tricuspid and mitral valves should be seen to open freely, and both ventricles should contract dynamically. On sweeping and angling the probe inferiorly, the position of the abdominal vessels can be seen, and of the fetal stomach. So the fetal stomach is seen here to the left, with the descending aorta anterior and to the left of the spine, and the inferior vena cava anterior and to the right of the aorta. Here is the normal four-chamber view again, and it can be seen as we sweep up and down that the fetal stomach and the fetal heart are on the same side. Just to point out one artifact here which sometimes causes confusion, and that is that when you go very inferiorly in the four-chamber view, you can see a structure here coming along the inferior border of the junction between the left atrium and left ventricle. This is the coronary sinus, but this can cause the appearance of the loss of differential insertion of the valve, the tricuspid valve here on the right, and the mitral valve. But if you look carefully, at the point where you see the coronary sinus, you don't actually see much of the mitral valve, so you're slightly below it. And if it's just that, as you pull up, you now see the primum septum normally to confirm that there is a normal primum septum there. And as you angle inferiorly, you see that again, this line of the coronary sinus. This is a normal finding, but it's important to recognize as something which may, if you're scanning slightly off axis, may cause diagnostic confusion. Occasionally these coexist where there is actually an atrioventricular septal defect, and in that situation, confirmation of the short axis views of the valve to confirm that the left AV valve is indeed a normal bileaflet valve is important. As we sweep up towards the left ventricular outflow tract, we are sweeping superiorly from the four-chamber view. And this is done to bring in the left ventricular outflow tract. And we can see in the diagram the aortic valve and the aortic root, which lie above the plane of the four-chamber view, which is shown by the blue planes below. We need to confirm the correct view by seeing the aorta as it leaves the left ventricle of the heart. We are making a very slight angulation upwards and slightly obliquely to bring in this view. We can see that we have now left the tricuspid valve below the plane of insonation, so we do not see this when we look at the left ventricular outflow tract. And what we would like to see is the left ventricle connecting to the aorta, which heads, as we see here, superiorly and to the right towards his right shoulder. We can also see that we're now beginning to move above the level of the right atrium and starting to cut the superior vena cava in transverse section. We identify the aorta by the fact that it does not bifurcate to supply the pulmonary arteries. Its only branches are towards the head and neck vessels, with continuation in towards the aortic arch. Very importantly, there is a line of continuity between the ventricular septum and the anterior wall of the aorta, which is lost in many forms of congenital heart disease, and it's important to confirm this as we scan. As we angle the probe towards the fetal head, the first vessel which we see, and I'll try and alter the insonation angle to make this clearer, the first vessel which we see is the aorta, which leaves the left ventricle and heads towards the right shoulder of the fetus. The aortic valve should be seen to open and close here, which is normal, and the septum and anterior wall of the aorta should be one continuous line as it's seen here. I'll just freeze the image to make that point, that this line of the ventricular septum and anterior wall of the aorta should be one continuous line, so that the aorta is completely committed to the left ventricle. As we scan more superiorly, we will bring in the right ventricular outflow tract, as shown here, and the sonographic cut shows us the right ventricle anteriorly, leading to the pulmonary valve, pulmonary artery, and duct, which head in a virtually straight AP anterior-posterior direction. And we can see the right pulmonary artery particularly easily in this plane, as it heads behind the ascending aorta. Both the ascending aorta, shown here, and the superior vena cava are shown in their short axis in these sonographic planes. As we sweep up again, we can see that the vessels, the pulmonary artery is defined by the fact that it branches into the branched pulmonary arteries. The aorta and pulmonary artery should be of approximately similar size, usually with the pulmonary artery very slightly larger than the aorta, although there shouldn't be a major discrepancy in their size. The pulmonary valve should be thin and mobile, and a good way to assess this is by the fact that it can't be seen during systole. It appears during diastole as it closes and disappears during systole. As the ultrasound transducer is angulated more cranially, the first vessel which is encountered is the aorta, which leaves in the center of the heart and heads towards the fetal right shoulder. The aortic valve can be seen to open and close here. On sweeping cranially again, the pulmonary artery is now seen, which takes a course directly anterior from the anterior chest wall through towards the spine, taking a more or less directly AP course here. The branching of the pulmonary artery can be appreciated here with the main pulmonary artery duct and the right pulmonary artery tucked under here. I'm just going to try and show that bifurcation a little better in a different projection here of the pulmonary valve, of the pulmonary artery. So we're going to see that this is the main pulmonary artery here coming out and bifurcating. Here we see the left pulmonary artery and then the arterial duct. So the pulmonary artery and the right pulmonary artery seen here, left, and the arterial duct just above the left pulmonary artery. So the pulmonary artery is a bifurcating structure in contrast to the aorta, which gives rise to the transverse aortic arch and does not bifurcate in the same way. The great arteries cross in their orientations as they leave the heart. By that I mean, as we sweep cranially, the aorta leaves the heart here, heading towards the fetal right shoulder in this projection here as it leaves the heart, whereas the pulmonary artery heads more or less from the front of the chest back. So the great arteries cross as they leave the heart. You should not see the vessels as they leave the heart lying in parallel. That would be strongly suggestive of transposition of the great arteries. Moving for the most superior view is a so-called three-vessel view. And what we have now done is move above the level of the right ventricular outflow tract. And we're now cutting these vessels as shown with the pulmonary artery and duct, the transverse aortic arch, and the superior vena cava in transverse section. So that the three-vessel view shows us the V of the pulmonary artery and duct, the transverse aortic arch here shown here, and the superior vena cava in short axis. I haven't in this diagram shown the trachea, but it's another important reference point which is seen posterior to the superior vena cava and should be seen to the right of the V indicated by these vessels. The trachea should not appear between these vessels, it should be outside of this V. As we come further cranially, we see the transverse aortic arch and the arterial duct. So we see the true aortic arch and the ductal arch forming a V. Of note is that the right superior vena cava is to the right here, shown in transverse section, then the aorta, and then the pulmonary artery. And behind the SVC, we see this bright cuffed structure, which is the trachea, and this lies to the right of the aorta outside the V formed by the aortic arch and the transverse aortic arch. So this constitutes a normal 3-vessel view with a similar size of the transverse aortic arch and isthmus here and the ductal arch. There should be no major discrepancy in the size of those structures. And those represent the key core screening views of the fetal heart which we'll be discussing.